So there are very few shockable rhythms, and they all are wide, complex, and ventricular. This is monomorphic VTAC, so this is a wide regular rhythm, and these are all wide irregular rhythms. So once you know what normal sinus rhythm looks like, none of these look like normal sinus rhythm. Every AED on earth is programmed to defibrillate wide ventricular rhythms. So once the AED kicks in and you hit analyze, if the machine sees any of these rhythms, these are your shockable rhythms. Defibrillate immediately and resume compressions and oxygenation. But keep in mind, when someone's doing CPR, you can't read the rhythm. But once they stop, if any of this is seen, defibrillate immediately and resume compressions and oxygenation. But if when they stop doing CPR, you see asystole or PEA, asystole and PEA are not shockable rhythms. Just push epi. So every code you go to is going to get compressions, oxygenation, and epinephrine, and only the lucky ones get defibrillated. Asystole and PEA are not shockable. They defibrillate asystole every night on television, because on television they got the actors a defibrillator as a prop, but they forgot to give the actors a simulator. This is why asystole is not shockable. If I take a real monitor or defibrillator and hook it up to a table, the table will appear to be an asystole. And if we defibrillate a table, it won't turn into a beating heart. So that's why they defibrillate that on television. But asystole is not shockable. There's nothing left to reset, nor is PEA. PEA is the weirdest thing, because when your patients are in a code, and you will see PEA in at least 25% of your codes, it looks like they're completely alive, but they're not alive. So PEA is pulseless electrical activity, and I know you'll see this in at least 25% of your codes. In fact, it likes to show up after asystole. PEA is pulseless electrical activity, but to keep it easy in your head, I just changed what everything means. P should mean poor IV fluid. IV fluid is going to fix half of your H's and T's. Your patient's still pulseless, you're still doing compressions and pushing epinephrine. The other E is the echocardiogram. It's the only way to diagnose a cardiac tamponade and then assess any leftover H's and T's. But you want to keep it in order and in order of importance. So when things fall apart and they go PEA in your brain, you just go poor IV fluid, epi, echo, assess, and keep it easy. But these are not shockable rhythms, and no AED will defibrillate these rhythms. These are your shockable rhythms, the wide ventricular ones, and every AED will self-charge for this. When it comes to defibrillation, some person is going to have to push the button. So realize they'll self-charge, but they won't just defibrillate the patient. Someone is going to have to say clear and push the button in every case. These are shockable, non-shockable. How easy.